Hello and welcome to lecture. My name is Dr. Andrew Craig, and the topic for today's discussion will be pharmaceuticals and exercise as the real polypill. Um, this is a very detailed lecture, so I'm glad that it's asynchronous, that you can go back and listen to the way that I've described things a couple of times if you need. But this lecture will sort of split up into two sections. The bulk of it will be a discussion about pharmaceuticals and common medications that I see in clinic that I think you should know as a rehab professional. And then the end of the lecture, we will talk about one specific study called Exercises the Polypill, which essentially it discusses in detail how exercise really affects multiple systems. So the circulatory system, the respiratory system, the musculoskeletal system, how it can be used to treat a number of ailments, and how it hasn't really gotten the respect that it deserves in terms of its strong effect on psychological health, cardiovascular health, musculoskeletal health, respiratory health, and we could really avoid using a lot of medications if we were more um, diligent as exercise and medical professionals to prescribe exercise over medications. That doesn't mean medications don't have a place. They certainly do. And a lot of clients that you will see, the vast majority of them will be on certain medications. And that's why this lecture is so important, because you need to have a baseline understanding of the most common medications that you see as a rehab professional. If you're thinking this is a rehab class, why do we care to learn these medications? Well, that's the reason. It's like you're going to see clients and patients with who are taking these medications, and you need to know if there's any significant side effects that could be affecting their rehab. You need to know if there's any contraindications to certain types of treatment modalities that you're going to use. So there's a plethora of reasons why you need to know the basics of these things. Most of you and me are not pharmacists. Like, we don't need to know the absolute nitty-gritty of these medications. What we do need to know is how it affects our patients and how it could potentially positively or negatively affect their rehab outcomes. And so that's why I've taken an entire lecture to sort of discuss these things. And what I've done is cherry-picked the most common medications that I see in clinical practice, because I think those will be very helpful for you to sort of focus your learning on pharmaceuticals.
So we'll talk about why do we care really about knowing what types of medications people are on, and how it can affect them. Then we'll talk about specific medications. So we'll dive into the most common forms of antidepressants. We will talk about different forms of pain medications and anti-inflammatories, things like NSAIDs or non-steroidal anti-inflammatories, over-the-counter and prescription. Then we will talk about a number of different cardiovascular medications, which are very common, things like beta blockers, anything to do with the heart and the cardiovascular system. Then we'll finish off the webinar with a discussion about an article about how exercise is the real polypill. People are always looking for something that's going to change their life in an instant, and on most times there isn't a medication for that, but there is exercise, which is this freely available, um, lifelong endeavor that we can do to help to reduce a lot of the negative sort of medical conditions that can come along with poor lifestyle habits. So we'll talk about how exercise can be used as that polypill to have overarching systemic effects on our body. At the end of the day, why do we as rehab professionals care about medications? We can't prescribe them. We can't actually give advice on medications. So why should we care about it? Truth be told, it all boils down to safety. Is the person in front of you contraindicated for certain types of exercise? Could they be telling you about a number of medications that maybe have interaction effects and are actually dangerous for the individual? This is what we really care about from a rehab perspective. How does it impact our experience with the individual? How does it impact our relationship and therapeutic alliance with that particular patient? That's why we care about medications. When we look at it from a more sort of point by point perspective, we worry about interactions. So, is the individual taking medications that might be having additive effects, Or maybe they have contrasting effects. If they're taking one medication that is supposed to increase their inflammatory response and one medication that's supposed to decrease their inflammatory response, those are contrasting ideas. Why would they be on both of those medications? We also want to know about side effects. A very common side effect would be fatigue, undue fatigue. One common example is beta blockers. Individuals who are on beta blockers often say, I just get out of breath so easily, not even doing any exercise. And it is a very common side effect with that cardiovascular medication. And so it's important, if you're going to be getting them to do aerobic exercise, to know that they'll likely be out of breath very easily. And maybe you have to be cognizant of that in a rehab scenario. Then we need to think about certain contraindications to specific types of exercise. So should we be focusing more on anaerobic exercise, aerobic exercise? Is there problems for lactate buildup? Are we concerned about strength and endurance exercises? Are they more prone to connective tissue injuries? So we shouldn't be maxing them out on certain exercises. We just need to know if there's any sort of musculoskeletal implications to the medications that they're on. We also need to think about, will they be able to recover as fast as we would normally anticipate for the individual? Sometimes recovery will take longer. Sometimes there's systemic effects where the gastrointestinal tract isn't uptaking as much nutrients, and so maybe the recovery takes a little bit longer. Does it affect their cognition? Is there some sort of cognitive altering effects that you need to be concerned about? From a safety perspective, you don't want them dropping a weight on their foot or on their chest when they're doing exercises. So you need to consider their cognitive abilities. And then we need to consider what sort of deficits in their abilities or what sort of impairments are they demonstrating that can be attributed to their actual condition or medical condition that they're seeking care for you from. From you for, or is it due to their medication? Do they have balance concerns? Is that because they have a concussion, or is that because they're on a medication that is altering their vestibular system? So these are all reasons why we care about what type of medications our clients are taking. So let's start with a discussion about antidepressants. Antidepressants are a very, very common prescription that you will see in a lot of your clients. And the three most common types we're going to discuss. So we'll talk about SSRIs, or selective serotonin reuptake inhibitors. We'll talk about tricyclic antidepressants, and we'll talk about lithium carbonate. The antidepressants typically target 4 different types of neurotransmitters. You've got serotonin as one of them, dopamine, norepinephrine, and epinephrine. And each different type of antidepressant sort of targets different neurotransmitters to a certain degree. So let's start by discussing the SSRIs, or select serotonin reuptake inhibitors. I apologize for this lecture. It is very, the slides are very dense with text, but that's because there's really not a great section of this in your textbook. So I want to make sure that you had the content in written form. So SSRIs are incredibly common. It's the most commonly prescribed antidepressant. And this is what we call a first-line pharmaceutical for the antidepressant effects. And many, many, many of your clients will be on these medications for management of pain, for management of depression, and for management of other psychological conditions like PTSD. So there's something called serotonin theory. Okay, so serotonin theory states that individuals who demonstrate depression also demonstrate lower levels of serotonin in their neurological pathways, which can regulate their mood and emotion. So the idea with SSRIs is we selectively inhibit the reuptake of serotonin from the synaptic cleft. What this does is it results in the serotonin is present within the synaptic cleft for longer periods of time, meaning it can bind to the postsynaptic terminal and exhibit an effect for a longer duration of time. So the serotonin theory essentially states that if we have an increase in the amount of available serotonin, This will reduce the amount of depressive mood disorders and the amount of sort of depressive and anxiety states moving forward. Okay. Most commonly, SSRIs are prescribed for anxiety disorders. This can be anything from like general anxiety, obsessive compulsive disorder, eating disorders, any sort of depression. And that's because serotonin is an important neurotransmitter for mood stabilization. It's also important for sleep. And it's essentially one of our primary neurotransmitters for transmission of signals across the synaptic cleft. 5-HTP, so I'm going to go back up to the top of the slide here. So 5-HTP or hydroxytryptophan, it's also known as oxytryptophan, I believe, or oxytryptophan. It's a naturally occurring amino acid, and it's an intermediate in the biosynthesis of serotonin. So you might find that some people take 5-HTP as a supplement. This isn't a prescriptive supplement. It's actually something you pick up at the whole or natural food store, 5-HTP. And the idea is that the supplement can supply the body with the precursors to generate its own serotonin. The idea being, if you're just taking oral serotonin, the body can break it down. If you provide your body with the 5-HTP or the precursor, that can help to build up the serotonin within the body and within the brain. Now, a lot of supplements claim to boost 5-HTP production, but the research is quite shoddy. So just to give you an idea, if you've ever heard of 5-HTP as a positive supplement. Now, the mechanism of SSRIs, I want you to know. So it increases the extracellular serotonin levels by inhibiting the reabsorption of serotonin into the presynaptic cleft or the presynaptic cell. Okay. What this does, if you look at, let's say we have a neuron interaction here. This is the presynaptic, this is the postsynaptic cleft. The presynaptic cleft is releasing that serotonin into the extracellular space, okay? But it reuptakes it constantly, or it reabsorbs it constantly and then can release it again. What the SSRI does is it prevents that reuptake of the serotonin. So then you have a higher concentration of serotonin between the cells, which increases the likelihood of binding to the postsynaptic cleft, which allows for the transmission of that mood signal. Now, SSRIs have the term selective in their name. They're called selective because they selectively affect the reuptake of serotonin specifically at the presynaptic terminal. Okay. TCAs or tricyclics, which we'll learn about in a minute, they affect all of the monoamine transmitters, and that includes the serotonin, the dopamine, and the norepinephrine. Okay. Typically, individuals who take SSRIs will notice side effects within the first month of taking the medication, but it takes a little bit of time to actually normalize within the system. So most of the side effects will be expected to dissipate within the first 4, 6, maybe 8 weeks. And that's why most family doctors or psychiatrists who do prescribe SSRIs, they will have a follow-up appointment in about a month or 6 weeks to make sure that the side effects are not persisting and they're not excessive and affecting the individual's ADLs or activities of daily living. So as the full effect of the SSRIs take place within, say, 6 to 8 weeks, you should see a dramatic reduction in the amount of side effects that the individual is experiencing. As I mentioned, SSRIs are the first line defense for antidepressant effects. Now, the question is, why do we care to use SSRIs over tricyclics or tricyclic antidepressants? And again, it's all about safety. Okay. One of the primary advantages is SSRIs have a much higher toxic dosage, whereas tricyclics are quite a bit lower. Okay. This means that there's a larger sort of safety window and larger therapeutic window that we can work in with the SSRIs, and we don't have to be as concerned with accidental overdose or potential unfortunate suicide attempts. Okay, so you need a higher dose of SSRI to actually cause an overdose, whereas tricyclics need a lower dosage. So it's just a safer alternative compared to the tricyclic antidepressants. SSRIs also have less and milder side effects than the tricyclic antidepressants. So the tricyclic antidepressants just have more aggressive side effects, and they happen more frequently. Tricyclics also have a higher risk of cardiovascular side effects. And so if anybody is taking cardiovascular medications or is prone to cardiovascular incidents or have them sort of in their genetic code or hereditary, then tricyclics might be a little bit more dangerous. Okay. So again, it all boils down to safety. SSRIs have a higher dosage that would be safely consumed compared to TCAs. They've got fewer milder side effects, and they're easier on the heart, so less serious cardiovascular events. Please do not feel like you need to memorize all of the side effects for these medications. You'll see that these lists are quite long. I don't expect you to memorize these. But I want you to know that serotonin is a neurotransmitter that's found throughout the entire body. So it can have incredibly widespread effects. The gastrointestinal tract can be affected, and serotonin does have a pivotal role in gut neurological transmission. So you get a lot of side effects that can negatively affect the gut. So things like nausea, dizziness, drowsiness. You can get appetite issues, changes to weight, vomiting, diarrhea. There's also some other side effects that can be quite negative. So issues with the kidneys or renal failure. You can get cardiovascular negative side effects like excessive vasodilation. And so I put all these side effects up here for you to recognize that serotonin is active throughout the whole body. And so the actual side effects can be very, very broad and very large in their range. They can affect every single aspect of the human body, essentially. Most people who are on long-term SSRIs will have multiple side effects. It's very, very, very common. This is one of the reasons that doctors will do multiple follow-ups, and they might sort of adjust the dosages that they're working with each individual. But these side effects should be mild to moderate. They should not be severe, and you can always sort of alter the dosage to try to get the proper dosage per person, because everybody is individual. Across the board, doctors are expected to begin treatments with the lowest dose possible and then increase as required. This also helps the body to become a little bit more used to the medication, so it's flowing through the bloodstream, and then you can increase to a more therapeutic dose as required. Here's a list of some common SSRIs that you might see, you may have heard of in the past. Things like Zoloft, Prozac, Paxil. These are very, very common medications. A lot of times, and these medication names change frequently, dosages change frequently. Patients are taken off this medication and put on that one for different side effects or interaction concerns. Personally, in a clinical setting, if I don't know what a medication is, I'm very upfront with the patient. Oh, let me just take a look. And so I will jump on the internet. I'll take a look at the medication. A lot of times you can find out if it is an SSRI pretty quick, or if it comes from a different grouping like tricyclics or lithium carbonate. So let's move on to talk about tricyclic antidepressants. And this is your second line defense in terms of antidepressant effects. So they're named tricyclics because of their chemical structure, which is three rings, hence the tri, meaning three, and cyclic, meaning in a cycle or a circle. For many, many years, tricyclics were the first line defense against depression, and they have been replaced with SSRIs because SSRIs have a higher safety protocol and they're very similar effectiveness for most people. Tricyclics are still considered highly effective, but again, for the reasons that they're a little bit higher risk profile, you need higher dosages, and there's other medications that do the same trick. We usually start with the SSRIs. Tricyclics are typically used for treatment-resistant depression. So if individuals have taken SSRIs for years or for months and they're not having positive effects, then a lot of times doctors might look to using tricyclics. So it's kind of your second line defense after SSRIs aren't really working effectively. These medications are usually taken at night because they do cause drowsiness. And for this reason, they can also be used effectively for sleep disorders, not just for mood disorders. So people who have troubles with sleep, doctors will try lower dosage sort of tricyclics. And interestingly, tricyclics dosage can be selectively manipulated for a desired effect. So its primary usages are for antidepressant and pain relief or analgesic effects. At very, very low dosages, we're going to see pain relief and analgesia. So if we're looking for the pain relieving effects, typically people will be on a very low dosage of TCAs. If it's specifically for antidepressant effect, it's a higher dosage. Okay, and this is where you get a little bit more into the risky dosages for TCAs. Tricyclics, the mechanism of action is they actually work by increasing the concentration of all of the tricyclic neurotransmitters in the central nervous system by inhibiting the reuptake of those tricyclics, which again makes them active for longer within the synaptic terminal. Okay, a positive sort of one point for tricyclics is that they're not technically chemically addictive. Okay, so from a chemical perspective, they aren't addictive, which is one of the attractive traits for treatment of mood stabilization and sort of any sort of sleep disorders. However, there are a number of significant contraindications to using tricyclic medications. Please feel free to read through these conditions. These conditions they place a person at an increased risk of negative side effects and negative outcomes when they're placed on TCAs. So a lot of times they will not be put on these types of antidepressants. Again, you're not expected to memorize these, but just know that TCAs, they're not really recommended for anyone who's adolescent, individuals with any sort of suicidal ideation, or anyone who has addiction concerns with alcohol or other types of central nervous system depressants. Given that tricyclics affect all types of tricyclic neurotransmitters, any area of the body that depends on acetylcholine will be affected by these medications. Okay. Acetylcholine is a neurotransmitter. It's highly abundant within the central and the peripheral nervous system for nerve conduction and signal transmission. And so it's responsible for a wide range of functioning, everything from like motor function to cognitive and memory and digestive functions. So if you're affecting the neurotransmitter acetylcholine, you're going to affect any part of the body that depends on that neurotransmitter. So the side effects can be quite diverse. And again, you're not expected to memorize these, but this is just a sort of inclusive list of side effects that can occur with tricyclic usage. The last antidepressant medication that we're going to discuss is lithium carbonate. Okay. This was originally used for a number of different ailments way, way back in the sort of early 1900s. It was used effectively for gout, renal stones, rheumatic disease, headaches, depression, It was kind of used for a number of different issues. And so it was lithium ions were found to have this anti-manic effect on the body. And that's what led to its use as a pharmacological agent to treat bipolar disorder, to treat mania, and essentially some of the literature says insanity back in the early 1900s. So manic depressive states, bipolar states were often treated with lithium. Less so nowadays. We don't see it as much, but once in a while, I do see someone who is taking lithium. Now, basically, the way this works is lithium ions interfere with ion transport within the sodium potassium pumps. And that is what relays and amplifies messages between neurons within the brain. So, mania or manic depressive states are often associated with irregular increases in protein kinase C activity. And so lithium carbonate inhibits protein kinase C activity. Okay. Out of all of this, I want you to remember that it inhibits protein kinase C activity. It is contraindicated in individuals who have cardiovascular or renal disease because of its interaction effects. And it does have a number of negative side effects, which can be quite nasty: balance and dizziness. It can cause some vertigo, those sorts of things. Interestingly, this medication has been around for a long time for manic depressive disorders and bipolar disorders, but the mood stabilizing properties are not very well understood. And so that's why when doctors don't understand medications, they don't often like to prescribe them, right? There's a kind of a perceived amount of control with understanding what it's going to do to the individual. So it's less often prescribed, and it's often that tertiary or third option after SSRIs and TCAs if they're ineffective. So the next grouping of medications we're going to look at are pain medications and anti-inflammatories. And specifically, we're going to talk about non-steroidal anti-inflammatories. Now, these are probably the most common short-term prescriptions and over-the-counter medications that I see patients taking. So they'll take them at their leisure. Some people take these very often. Some people are a little more cautious when they're taking these medications. And we're seeing a lot of sort of literature emerging from people overusing these medications because they are kind of over the counter and no prescription needed. Now, this is a non-exhaustive list of anti-inflammatories and pain medications, but I'm sure you're familiar with a number of these. So acetaminophen and paracetamol, which is Tylenol. You've got ibuprofen, naproxen, diclofenac, and ASA, or acetylsalicylic acid, which is aspirin. So we're going to talk about the different types of effects that some of these medications may have. So NSAIDs, or non-steroidal anti-inflammatories, what do? Anti-inflammatory. So they reduce inflammation, and they don't use steroids to do so. Since they are non-steroidal, that's why they are allowed to be sold over counter. So how do NSAIDs work? They essentially work by reducing inflammation through inhibition of the COX-1 and the COX-2 enzymes, which are the primary enzymes that convert arachidonic acid to prostaglandins. Okay? Prostaglandins are a pro-inflammatory mediator. Okay? So prostaglandins within the tissues they'll mediate pain, they'll cause inflammation, and they can cause fever as well. Now, these COX enzymes, COX-1 and 2, are two different isoforms of each other. They are located all over the body. So they're in your blood vessels, they're in your liver, they're in your kidneys, they're in all of your immune cells. So their job is to react to different types of injury in terms of immune cell function. They also have some regulatory functions within the viscera, so within the liver, the kidneys, and systemically through the blood vessels. And so COX-1 enzyme is always active in the body. This is the enzyme that we see in the kidneys, that we see in the heart, that we see in the liver, or sorry, that we see in the heart and that we see in the stomach as well. COX-2 enzymes, on the other hand, these are predominantly active when you injure a tissue. So let's say you cut your hand. I played hockey last night. We'll use that as an example. I sliced my hand open on my hockey skate. Starts to get red, and we see some inflammation starting to occur. What this is we've activated those COX-2 enzymes, which are transitioning arachidonic acid to prostaglandins in order to mediate that inflammatory response. Okay. Common examples of NSAIDs are listed on this slide too. And you'll see that there are some that are selective to certain enzymes. So a great example is aspirin is a COX-1 inhibitor. So it selectively inhibits that COX-1 enzyme. Tylenol selectively inhibits that COX-2 enzyme. Now, let's remember, and I want you to understand this, the difference between the COX-1 and the COX-2 enzymes. COX-1 enzymes are present within the kidney, within the heart, and within the stomach. Okay, so they're not just present within the peripheral tissues and the immune cells. That means if we are inhibiting this enzyme, it's going to have an effect on all three of these sites, right? The stomach, the heart, and the kidneys. So let's look at each of these individually. If we are inhibiting the COX-1 activity in the stomach, it's going to cause gastrointestinal issues. Okay. So COX-1 inhibition in the gastrointestinal tract, this is going to result in a buildup of acidity, epigastric pain, nausea, vomiting, ulcers, and hemorrhages within the stomach. So if we're constantly using a medication that is inhibiting this function, we're going to have issues chronically within the stomach. Okay. So if that's a concern for us, if we don't want to inhibit that COX-1 enzyme, what we can do is we can preferentially utilize selective COX-2 NSAIDs, or medications that only affect or only inhibit the COX-2 enzyme. In that way, what we do is we spare the function of the COX-1 enzyme, and it can continue to function within the stomach and reduce the risk of gastrointestinal issues. Now, how does it affect the kidney? Okay. Basically the same is true for the kidney. So the COX-1 enzyme is highly active within the kidney. And when we reduce prostaglandin synthesis in the kidney, it's going to alter the renal blood flow because COX-1 is present within the arterial system. And what can result here is nephritis or inflammation of the functional unit of the kidney, which is the nephron. So we will cause inflammation in the nephrons of the kidney, and this will cause inflammation within the kidneys. Okay, so again, how can we avoid that? We can utilize medications that only inhibit the COX-2 enzyme and spare the COX-1 enzyme, so it can continue to function appropriately. Lastly, we'll talk about how it affects the heart. So since prostaglandins regulate the vasoconstriction and vasodilation of the blood vessels, it's going to affect our cardiovascular system. Okay. We also need to be considerate of the fact that prostaglandin formation affects the ACE inhibitors. So ACE inhibitors are a medication that's used for the cardiovascular system. And so anybody who might be on ACE inhibitors, we need to be careful if they're using COX-1 inhibitors as well. Okay, but we'll talk about this more later when we talk about cardiovascular medications. This is a nice little summary slide of selective versus non-selective NSAIDs. Okay, non-selective NSAIDs they're going to affect both the COX-1 and the COX-2 enzymes. So they're going to inhibit the function of both of those enzymes. When we're inhibiting the function of both of those enzymes, we are prone to the effects that we just discussed. So the effects on the kidney, the heart, and the stomach. So why would we ever use these NSAIDs if we have selective ones available to us that can spare the stomach, the kidney, and the heart? Well, these non-selective NSAIDs have some favorable effects. So both selective and non-selective NSAIDs have anti-inflammatory effects, but if we want to reduce fever or high temperatures, and if we want to reduce pain, we need to use the non-selective NSAIDs. So they have a trifecta of effects. They have antipyretic effects, meaning they can bring down your fever. They also have analgesic effects, so they have a pain relieving effect. And then they also have that anti-inflammatory effect. Okay, but there's a trade-off because it does have higher risk for negative side effects. Let's say we don't have fever and we're not so worried about the pain. We just want to bring down inflammation. This is when you would use a selective NSAID because it's just going to reduce that COX-2 enzyme activity. Okay. If you want to learn more about the difference between these, please feel free to watch this video, which is a great description of these two. Now, paracetamol, I'm not going to make you learn too much about this because it can be quite confusing, but Tylenol, also known as paracetamol, it's a bit of an enigma, okay? And it's in kind of its own ballpark because it does have a pain-killing effect and a fever reduction effect or antipyretic effect, but it does not reduce the inflammation, okay? Now, its mechanism of action is not terribly well understood, but it's believed that it works by inhibiting some enzyme form of the COX enzyme, okay? So please review the non-steroidal anti-inflammatories because it is important that you understand their usage. I think you'll run into it a lot in your career. Moving on to cardiovascular drugs. Cardiovascular drugs are very, very common. It's probably the most common long-term prescription that I see people taking, and a lot of people are typically on multiple cardiovascular drugs. So things like blood thinners, beta blockers, calcium channel blockers, those sorts of things to manage a number of different types of cardiovascular concerns like hypertension, congestive heart failure. This slide provides you with a list of a number of different cardiovascular diseases that have common medications that are prescribed to manage them. Now, a lot of these, please don't memorize these. You're not necessarily expected to know every single medication that treats each of these conditions. Some of the medications that we discuss over the next few slides, I want you to know and understand what they're treating, but don't just go ahead and memorize this entire list. Remember, most medications have side effects, and so sometimes when you've given a certain medication, it might be introducing a distinct side effect to that individual, and then potentially you need another medication to manage that side effect. And so sometimes that happens with cardiovascular drugs, but a lot of the time it is sort of the less of the two evils because we really don't want to mess around with anything that's increasing our chance of cardiovascular events in the body. Okay, so we're going to focus mostly on ischemic heart disease, which can cause angina. We'll look at some different types of arrhythmias that can happen, which are problematic rhythms within the heart. So the heart rate or heartbeat is beating improperly. Hypertension is just high blood pressure, which I'm sure that you will learn to measure in one of your courses here at Ontario Tech. Then congestive heart failure and myocardial infarction. Myocardial infarction is the medicalized term for a heart attack. So let's start by looking at a couple of anti-anginal medications. Okay. So angina refers to chest pain due to coronary artery disease. So coronary artery disease is when your heart doesn't get adequate oxygenated blood, and it often feels like there's a pressure or a squeezing sensation in the chest. Some people will report feeling like an elephant is standing on their chest often. And so it's this significant pain in the chest. And oftentimes these patients are prescribed some combination of nitrates, beta blockers, and or calcium channel blockers as well. Now, nitroglycerin is an interesting medication. It is generally administered as a spray that's applied underneath the tongue. And it's a very, very effective vasodilator. So it dilates the blood vessels. Nitroglycerin, we spray it under the tongue because there are glands under the tongue and it can be rapidly absorbed into the bloodstream, and it skips over what we call the first pass effect. So the first pass effect is when you take medication orally, your digestive tract sometimes can filter out a little bit of the medication, and it can actually reduce the effects, especially as it passes through the liver. So the first pass through the liver sometimes reduces the effectiveness of a medication, the potency. So by spraying nitric oxide directly underneath the tongue in a very free form, your body can uptake it in low dosages to have a strong vasodilation effect. So what does nitroglycerin do? It promotes production of nitric oxide from the smooth muscle, and this induces vasodilation, and it improves the cardiac blood flow through the vascular system. So when the heart gets more oxygenated blood supply, you get reduced angina or chest pain. You get less of a pain signal coming from the chest. So it reduces the preload, and to some extent, it reduces the afterload of the heart. Beta blockers work by decreasing the heart rate and the contractility of the heart. This in turn reduces the oxygen demand. Okay, so you're reducing heart rate and you're reducing the contractibility of the heart. It also has a nice secondary effect of a antihypertensive, so it reduces the blood pressure because it is reducing the heart rate and the contractibility of the heart. You're going to have a reduced overall pressure within the vascular system. The third medication here is calcium channel blockers. And so calcium channel blockers, they cause vasodilation of the peripheral tissues. So the peripheral arteries in particular, which means that blood flows much quicker through the body. So it's kind of the afterload is reduced. So it's easier for the heart to sort of pump blood through the arterial system. This means that we reduce the peripheral resistance to blood flow, and this can in turn reduce the anginal effects of congestive heart, of coronary artery disease. Next, we're going to talk about some anticoagulant medications, and these are also known as blood thinners, which are very, very common. In order to understand what blood thinners do, we need to understand what platelets are. And platelets are these small fragments within our blood that congregate to form clots, and they help to stop bleeding. So they actually help to sort of thicken up the blood, and they create a clotting mechanism that helps us to reduce our potential bleeding. The trouble is when clots form within their arterial system, they can dislodge, they can block blood flow, which can cause stroke, heart attack, and other life-threatening cardiovascular conditions. Thick blood also has a very high viscosity, which makes it harder to pump through basically the pumping of the arterial system. And this will increase the strain on the heart. So the heart has to work harder to actually push thick fluid through a closed arterial system. So think about it like, would it be easier to pump water through let's say we're using a water gun. Is it easier to pump water through a water gun or a thicker substance like maple syrup or molasses? Probably water, right? The actual pumping mechanism has to work a lot harder to push maple syrup or molasses through the actual water gun. Same thing is true for the heart. Okay, so thicker blood is typically harder for the pump or for the heart pump to actually exert force against. So the way that anticoagulants work is they essentially reduce the risk of heart attack and stroke by thinning out the blood. Some common examples are shown on the slide here. So aspirin is probably the most commonly prescribed one. I think probably because it is readily available over the counter, and it's a rather trusted medication for as a blood thinner. There's other prescriptions that you can get. Coumadin is one of them, and this one essentially interferes with the formation of the actual clotting factor. The next classification of medications are anti-hyperlipidemics. Okay. I want to break this word down. So anti means it reduces or it goes against. Hyper means increased, and the opposite would be hypo. So with hypertension, that means high blood pressure. Hypotension would mean low blood pressure. So in this situation, we're looking at hyper, so increased lipid levels, lipidemics. Okay, so lipid. So how do anti-hyperlipidemics work? They essentially promote reduction of lipid levels within the blood. Some medications aim to lower the levels of LDLs, or low density lipoproteins, or low density lipoprotein cholesterol. Some reduce triglyceride levels, and others help to actually raise the levels of HDL, or high density lipoprotein cholesterol. And what this does is it actually helps to even out the ratio of LDL to HDL cholesterol. Okay. These medications are used to prevent the buildup of plaque in the blood vessel walls. And the reason for this is buildup of plaque on the vessel walls can actually narrow the vessels, which increases the blood pressure. It makes it a lot harder to push. It makes it a lot harder to push the same volume through a smaller channel. These plaques can also dislodge from the edge of the blood vessel, and they can travel downstream or upstream and cause a clot to form. So they can clog the vessel and reduce blood flow to certain areas. Common problems where we see this are things like stroke, right? So if you get a dislodged plaque that travels to the brain, it gets trapped in a narrow vessel, it can reduce the blood flow to the brain and cause a stroke. This can also happen in the lungs, where you get reduction in blood flow to the lungs. Okay, so these are big problems, and a lot of people are on these anti-hyperlipidemics for this reason. So we've got a few different types of medications that are effective in this situation. So you've got bile acid sequestration, or sequestrants, so bile acid medications. And these essentially increase the liver LDL receptors, which reduces the absorption of dietary cholesterol altogether. Okay, so it reduces our absorption of that cholesterol. The next medication is niacin. So niacin reduces cholesterol synthesis, and it also reduces the actual release of cholesterol from the liver. So it decreases the LDL production, and it increases the HDL release. Statins, or HMG-CoA reductase inhibitors, or commonly known as statins, which a lot of people will be familiar with. These work by increasing the liver LDL receptors. Okay, these are the most common form of anti-hyperlipidemics, and it's because they're very powerful, they're effective, and they're often prescribed in conjunction with other types of medications that help to bring down the blood pressure. The last medication here is fibrates, and these actually reduce the circulating triglycerides within the bloodstream. Okay. Now, there are some significant side effects with these medications, so they are often closely monitored by the individual's family doctor. I've touched on this, but we're going to talk about hypertension. Okay. Hypertension means high blood pressure. So when we use antihypertensive medications, the goal here is to reduce the blood pressure. Now, we use a stethoscope and blood pressure cuff in order to measure blood pressure. There are free ones that people can use to keep an eye on their blood pressure at Shoppers Drug Mart. People, they're very inexpensive now to get an automated system. Anybody who has high blood pressure, I usually recommend to get one for home use just to monitor their blood pressure over time. But what we're looking at here is chronic high blood pressure in the vessels predisposes your body to a number of poor health outcomes or adverse health states. Okay. It's very hard on your heart to continue to pump. It's very hard on the organs to have high pressure blood coming through them. So an example is in the kidneys, if you have very, very high blood pressure, that's providing blood to your kidneys, it's hard on the nephrons to actually keep up with that. Okay, so there's a number of health concerns we have with high blood pressure, and that's why it is, in my opinion, probably the most common reason to actually medicate someone for cardiovascular concerns. So the indication for actually utilizing this medication is to reduce their elevated blood pressure, and this is done by reducing the demand of the heart. And it is also done to reduce any sort of risk of heart attack or stroke. Okay. I want you to know the chart on the right. This indicates normal levels of blood pressure. It will tell you what an elevated state is. It will tell you what high blood pressure is considered, stage 1, stage 2, and stage 3 hypertension. And I want you to pay close attention to this last one here. So normal is 120/80 or close to hovering around 120 millimeters mercury of systolic and 80 millimeters of mercury diastolic blood pressure. As we go through the chart, there's elevated numbers. If an individual is over 180 systolic or 120 diastolic, this is what we call a hypertensive crisis. They should be seeking emergency medical care. Okay. Now, as an aside, hopefully you've learned this in other classes, but I often get asked, what's the difference between systolic and diastolic pressure? Think about when the heart pumps. So when the heart pumps, it's exerting blood out of the heart, right? It's literally a pump system. So it's pumping blood as hard as it can out of the heart. When you're pumping the blood, the pressure is higher in the arterial system. This is what we call the systolic pressure. Okay, this is the highest pressure in the cardiovascular system. Diastolic is the pressure when the heart is not pumping. So it's almost like, it's not quite a resting pressure, but if you were to think about it from a very simplistic perspective, it's more along the lines of the resting pressure when there's no heartbeat pumping. There are 5 primary types of antihypertensives. And so I want you to know the difference between these. You've got diuretics, also known as water pills, and these essentially reduce the blood volume by eliminating the salt from the body through renal clearance. So renal clearance meaning through the nephrons and through the kidney excretion. What this does is it reduces the amount of overall blood plasma, so the overall blood volume, and it reduces the blood pressure as its sort of final goal. Okay. Beta blockers reduce, as I've mentioned before, the heart rate and the contractibility of the heart. This reduces the overall turnover of blood and reduces the amount of pressure being extruded from the heart. ACE inhibitors, these actually block the conversion of angiotensin 1 to angiotensin 2 in the kidneys. Okay. The reason for this is angiotensin 2 is a potent vasoconstrictor, so it constricts the vessels. So if you're reducing the production of it, you're going to have an inadvertent vasodilation effect. Okay. The calcium channel blockers, these reduce the peripheral resistance, as I've mentioned before. So they induce vasodilation to the peripheral tissues and reduce that actual vascular resistance in the periphery. Finally, alpha blockers, these also induce vessel dilation, but they're somewhat less common than the other medications. I see these very, very commonly. Alpha blockers, less so. The last cardiac condition I'll really want to talk about is arrhythmia issues. Okay, so an arrhythmia is an altered heart rhythm, and anti-arrhythmic medications are used to prevent and treat these abnormal heart rates. Okay, so if somebody's heart rate is excessively high, you want to bring it down. If their heart rate is excessively low, you may need to bring it up. Or if it's just offbeat, so let's say it's not consistent, you need to stabilize that rhythmic contraction. Okay, so antiarrhythmics, they're used to stabilize dysarrhythmias. Okay, dysrhythmia meaning altered rhythms. I want you to know the difference between bradyarrhythmias and tachyarrhythmias, bradycardia and tachycardia. Essentially, bradycardia or bradyarrhythmias. This is when you have a very low heart rate, so less than 60 beats per minute, and that number is relative. I've got athletes who come to see me, their heart rates are 32, 38. They're actually very, very healthy. Truly, you need a low heart rate and it needs to be irregular. Okay. Medications for bradycardia usually block the parasympathetic nervous system, and then they activate the sympathetic nervous system to actually increase the heart rate. Tachycardia or tachyarrhythmias, these are excessively high heart rates and irregular beats. Okay. There are 4 different classifications of medications that are used. However, you're not required to know the difference except for I want you to understand what each medication does, beta blockers, calcium channel blockers that we discussed on the previous slide. Now, we dove deeply into a number of different medications, and to be perfectly frank, it's beyond all of our scopes to be giving advice on these medications. Okay. So, this information that we're talking about today, I want you to know it. It's very important for you to know as a rehab professional, but it's for our understanding only, to understand our clients. And if we see indicators, to recommend that they discuss it with their family doctor or their cardiologist. You're not supposed to be giving any sort of advice as to whether individuals should be taking, stopping, starting these types of medications. And it can be very, very dangerous to start giving that advice. So you are not, I'll repeat, you are not expected or even allowed to be giving recommendations on this medication. If people have questions, what you can do is you can refer them to their family doctor, you can refer them to their cardiologist, and give them a bit of advice as to, I always say, you shouldn't be stopping your medication without the consent and the observation of a medical professional who actually prescribed the medication. Okay, it can actually be quite dangerous for you to be giving advice on these medications. And a great example is if somebody is having a stroke. Okay, if it's a hemorrhagic or ischemic stroke, the treatment is very, very different. Okay. Ischemic stroke, if there's a blockage, obviously we are trying, the treatment in the hospital is to break up that blockage, so they give blood thinners. However, if it's hemorrhagic, so let's say there's an active bleed in the brain, if you give that individual blood thinners, you are going to make their hemorrhagic stroke worse, and it's actually very, very dangerous. So again, you shouldn't be giving advice on medication. Always refer to the medical professionals. And that sort of concludes our discussion about specific medications. Okay. The next part of this lecture, I want to expose you to an excellent article that I found about how exercise can be considered this polypill. Okay. And it's the idea that exercise, everybody's always looking for that quick fix, right? How can I have high blood pressure? I have angina. How can I fix that? I want to take a pill that fixes everything. When really the answer's been in front of us the whole time, right? There's no quick fix to anything in life. And this is particularly true in medicine and rehab. Truly, one of the best things we can do, and what we should be sort of encouraging our clients and our patients to do, is engage in regular habitual exercise. Okay. This article, which I'll give you this is the reference here, Exercise is the Real Polypill. I love this article because it reviews the benefits of regular exercise on preventing cardiovascular disease, and it actually compares those effects to common medications that are used to manage cardiovascular issues. Okay. It does a great job of summarizing epidemiological evidence on the preventative and therapeutic benefits of exercise, and then it compares that to the epidemiology and evidence that supports common medications that target the same effect. Okay. It's quite an interesting article. It's one of the first I've seen of its kind. It's getting a little bit older. It's a 2013 publication. So really what I should do is kind of a little bit of a lit search to see if there's updated evidence in this regard. But I want you to go through this article and take a look and read through it, because it's a great article for any rehab professional to have in their back pocket. Kind of to echo what I said a few moments ago, heart medication is very important. We are not to be telling people to stop their heart medication. Okay. They need to make sure that their cardiovascular health is of top priority. If they're interested in it, and I do get people coming to talk to me about, I want to reduce my dependence on my beta blockers, calcium channel blockers. I want to reduce my angina, the blood pressure, all those sorts of things. I always say, great. We need to do this in coordination with your family doctor. Your family doctor needs to be updated, and you should not be stopping your heart medication. We can start to include exercise to get some of the benefits of it, but this needs to be done in an observed, highly controlled setting with their family doctor. So where did the idea for this article come from? It kind of came from the idea that this idea of a polypill, which has been sort of at our fingertips the whole time for cardiovascular disease. Okay. And it's called exercise and stress reduction. What is this idea of a polypill? But 20 years ago, the World Health Organization and a group of experts came up with this idea of formulating a medication that contains aspirin, statin, and 2 blood pressure lowering medications that are commonly prescribed together. Remember, I said that a lot of people are on a number of medications. Well, the World Health Organization basically said we could reduce the cost of this if we just combine all of these medications into what we call a quote unquote polypill. Okay, so poly meaning multiple medications in one single pill. This isn't the first polypill that's been developed. There's also a aspirin and ibuprofen polypill that has been very, very common in the United States and just got approval in Canada. But this is the first one that was going to be a preventative cardiovascular medication that people take to reduce the risk of future cardiovascular events. Okay. Now, the idea behind this polypill was to reduce the overall cost associated with it, especially in low to middle income countries. So this article suggests that the effects found with long-term habitual exercise can actually have stronger effects than medications in the prevention of cardiovascular disease. It also impacts multiple body systems. There's virtually no adverse consequences to exercise as long as you're doing it properly, and it costs $0. So for something that's cheap, safe, and effective, exercise, why are we making a polypill that can be quite expensive and have a lot of side effects to manage those things, right? And the idea again is we're often looking to these medications as quick fixes, whereas exercise, as you all know, takes time, takes effort, takes dedication. Interestingly, our body produces a lot of the substances that aid in pain suppression, muscle building, and that can overall improve our ability to manage pain. Exercise can upregulate genes that regulate our metabolism and regulate our inflammatory processes within our system. So our body has the natural necessities to be reducing inflammation, to be managing hypertension and cardiovascular events. But if we're not exercising adequately, then we need to start to look towards medication. Okay. A lot of the medications that we use are actually meant to mimic molecules that our muscles produce. And so by just using our muscles more, we can produce more of these drug-like molecules. The one benefit that exercise has over a polypill is that exercise helps to maintain our muscular fitness. Okay. And muscular fitness is important to ensure that we're able to continue our activities of daily living throughout the lifespan. So even if you do take a polypill to reduce all of the cardiovascular concerns, you still have to have fitness in order to maintain your muscle mass, right? So if you just start with exercise from the get-go, then you don't have to rely as heavily on these medications. Now, there are three major trends that support the idea that exercise is better than a polypill in terms of regulating against cardiovascular disease, and we're going to briefly touch on each one of these. So the first one is that exercise protects against most cardiovascular risk factors that drugs try to target. Okay. That includes everything from lowering our blood pressure, lowering our lipid levels, regulating our cholesterol levels, improving our glucose tolerance, and so on and so forth. Everything from inflammation to hormone and metabolic regulation. Okay. Exercise affects all of these risk factors, whereas medications typically only target one. So if you have glucose regulation issues like diabetes, then you have to take a medication for that. But if you also have high blood pressure, you're going to have to take a medication for that as well. And then if you also have a lipid issue or a cholesterol level issue, you'll likely be on another medication there. So you can see how adding all of these different medications starts to accumulate quite easily, where exercise can actually regulate all of these factors. It's important to note that if somebody starts to exercise tomorrow, they're not going to see results next week or the month after. This has to be habitual. It has to be over time and built up, right? And so I always say consistency is king, especially with exercise and dietary recommendations. The second line of supporting evidence is that exercise actually attenuates the nervous system. As we age, we typically get an increased drive to our sympathetic nervous system in the peripheral tissues. And this can actually lead to poor blood supply in the legs. It can lead to increased arterial blood pressure. It increases our barrel reflex response, which regulates blood pressure and causes hypertension. So exercise can actually help to normalize and regulate the central nervous system. And it can give us a finer balance between our sympathetic and our parasympathetic nervous system responses. The last sort of line of evidence that I want to introduce you to is what we've talked about this whole time, that exercise really does have that polypill-like effect, okay? It is compared repeatedly to common drugs, and it's been shown to be comparable in many regards to reducing risk factors like high blood pressure, like high cholesterol, like angina. And again, the muscles actually produce the same active ingredients that medications try to mimic. And so this isn't by accident. A lot of times the medications are designed to copy what the body's natural processes are. This helps the medication to be more in line with our natural body composition, and it also helps the medication to be accepted more readily by the body. Okay. Exercise has also been shown to stimulate adult stem cell proliferation and migration from the bone marrow, which helps to improve our cell regeneration, recovery time, and improve our recovery time overall. The last part I want to bring to your attention is exercise does help to upregulate antioxidant production, and it promotes autophagy for cellular recycling. So autophagy is when cells decompose and are eaten essentially by other cells, so that we can basically use the raw materials for recovery and for building other substrates. Okay. So I want you to take the time to please go through this article. I'm going to post it to the course website. And you don't need to go through the nitty gritty. It's kind of a longer article. I just want you to get the gist of each of these sections as you read through it. Okay. I hope you enjoyed the lecture. I know this one's a little bit different than previous lectures because since we've made that transition away from the anatomical rehab aspects, but it's important for you to understand some of these medications. Okay. Next week, we're going to move on to touch on some more higher level rehab concepts. And we're almost there. Just a couple of more weeks before the end of the semester. Keep going, everybody. You're doing a great job. And we will see you on Monday for some more presentations. Bye now.